All right, so I'm so happy today to introduce Dr. Peggy Papathakis. She's one of our excellent professors of nutrition here at Cal Poly. After many years of working as a clinical dietitian working in pediatrics at the UC Medical Center, she earned her doctorate at UC Davis in nutritional biology with an emphasis in international nutrition. Now, here at Cal Poly, she's often teaches the clinical series. She generally is always the person teaching maternal and child nutrition, and she also works in a variety of research projects. Her research has involved maternal and child health both here and in Africa. And, Peggy, the students in the clinical, too, haven't gotten a chance to meet you as much as lots of the other students have. Mm-hmm. But right now they're working in their project on inborn errors of metabolism. I thought it'd be just great if you could share some of your experiences with them, working as a pediatric dietitian, and specifically what you ended up working with when you were working with families, children, people with inborn errors of metabolism. So just to let the students know a little of your background, how long were you at the UC Medical Center?
So I was at UC Davis for about 25 years, so a really long period of my life. More than half my life was there. And it was a great opportunity when I was working in the outpatient realm that they needed a dietitian to work with patients with metabolic disease. So we were a regional center, meaning that anybody with the newborn screening, babies are screened for like 22 or 25 different inborn errors of metabolism when they're born. And so if they're anywhere in Northern California outside of the Bay Area, they'd be referred to us for follow-up. And so I worked closely with a geneticist and with a nurse specialist and a social worker. Wow. And so we would have metabolic clinic is what we called it, and we had that every month. So it would just be a morning, and one time a month, and I could only see 4 patients because it took 4 hours, and that was just seeing them and reviewing all their information. Okay. Then I took another 3 hours to write up all my notes on them because you have to pay really close attention to detail, and you're looking at, it could be urine analysis for spilling certain amino acids in the urine. So you could be checking for that. Right. You could be looking at, what were their what are the limiting amino acids? What are their problem ones depending on what their disorder is? And then you'd look at their whole metabolic, all the amino acids, and you'd see, they need more of something to push that through the cycle, or they need less of something else. Okay. I'd still have to do, of course, the diet history, find out was the child sick, was anything wrong. So it would take probably 30 minutes for me to just get ready to go see the patient.
So there's the first time they see you, and that's from a doctor's referral, straight up from
their genetic screen. And the nurse that I worked with got all the results. So she would follow up to find out, where those babies were. And then they make sure that they would work to get them in.
Okay. So following up on that then, how often would you see a person with one of these conditions?
So I would see them, it depended on how well they were doing, but babies, since they're growing and we want them to grow, and their protein needs are changing first half of infancy versus second half of infancy, those we would see more often. Something like every 3 months we would be checking to readjust. Are the calories where they should be? Because you're usually, for many of the errors of amino acid metabolism, they were on special formula, and then you'd use a tiny bit of like Enfamil to get in this very limited amount of their limited amino acids that they could get. So the formula might be devoid of the ones that they couldn't tolerate, and then you'd have to figure out how much of Enfamil they would add to it to get right up to the guidelines.
So you're trying to get calories in. You're trying to get essential fatty acids in.
And
you're trying to get a crazy profile of amino acids depending on what they have.
Yeah, absolutely. And I just have to show this protocol that costs $500, right? So this, I call this,
how fat is that?
My Bible.
Wow.
Because some of these patients, you would never have seen that again, nor will you ever see it again.
Wow.
So only had one patient with methylmalonic acidemia, right? So you have to look up, okay, what exactly am I going to do? And there's food charts for how much of all these different amino acids. I'm going
to get a little close up on that, just to, so if the person has, for example, one amino acid that's out of whack, then you're looking at an entire profile then.
Yeah, of what it is that they're eating that could be contributing to that. Mm-hmm. Do I need to increase something? Do I need to decrease something?
Wow.
So anyways, and we limited protein. So, and that's why this book, I'm sure now it's electronic and online, but this gave you all the references. And so that's how you could, I might only see one child with a particular condition of amino acid metabolism problem.
Wow.
And so it's like, okay. And I once, several times actually, I had to go to court with problems with some of these kids with inborn errors of metabolism. And I explained...
Give a little background on that. Why would a person have to be an expert witness or go to court on somebody?
Because maybe a parent was overwhelmed and wasn't following the directions appropriately.
Right.
Maybe they didn't understand it. So maybe it was intentional because their child could have horrible developmental delays and they didn't really want that child anymore. Right. So anyways, that was a different category of patients. But
any with the fat storage problems, disorders of fat metabolism,
carnitine deficiency,
carnitine,
and there's another one, not
taurine,
not a taurine. No, it was medium chain, MCAD, MCHAD.
Really?
So there was less active dietary intervention.
Okay.
Compared to the ones with the amino acid or the carbohydrate.
Amino acid's big.
Yeah.
And then those amino acids ones, also we tend to think of people having cognitive problems over time. What can and can't you accomplish with diet? Were parents concerned with that, or were expectations on track with reality?
So I have a great one of those. So this little girl had citrullinemia. So it was, you think I'd remember... I knew all these pathways right at one point. If I had Dr. Reeves, I'm sure would know it. But she had to take sodium butyrate and other things to help drive a pathway.
Wow.
Anyways, so we had her on a kind of a low protein diet because her ammonia level was always high.
Right.
And she was a little slow. And so we thought, oh well, she's just slow. And then she had some event that put her into the hospital. And we actually found that if her serum ammonia was lower, she was much more bright.
Isn't that interesting?
And so we were that's a case where we were just accepting, oh, this is just the way Michelle is.
Right.
But then we had an opportunity, kind of by accident.
Right. Isn't that great?
Oh, it's wonderful.
Yeah, right.
It's wonderful. And the family was so thrilled because they thought she was a little dull too.
Right.
And it's like, oh, well, that's just Michelle. Right. And then it's like, oh, we're going to change this up.
Oh, that's pretty
so
nice.
It is really nice. See that, so you kind of, that's a case where you made an assumption.
Right.
Oh, she's just slow.
And in reality, a little bit of...
Yeah. And so we allowed a higher ammonia for her because that's otherwise you couldn't get in the calories, enough protein for growth, all these other things. And then we thought, oh, we probably made a mistake on that. We probably shouldn't have allowed it to be so high.
Interesting.
So, anyways, yeah.
So I guess that kind of actually brings me to this last question, and that's, what advice would you have for someone who might eventually be working with a person with one of these metabolic errors?
I'd say you have to love problem solving.
Okay.
And I love problem solving. It's a really fun aspect of clinical practice. And I also think I loved and still love working with families because you have all these different dimensions. And so the more you enjoy interacting with families, with the kids, with the mom, the dad, anything, you get all sorts of really valuable information from that. So you have to really like families.
Oh, yeah.
Because for the good and the bad of it. You see a lot of dysfunctional families, and that's really hard. You see kids who are really, are they like this because they're sick? Or, which came first? Are they just horrible? Really tough
and what can
kids?
you do about that,
Yeah,
right?
and
That's a separate issue.
How can you help the family deal with whatever that is? And that's why working with a social worker is phenomenal, because they can sort out all the other issues, that I might not know about. So you have to be ready for the good and the bad. It's a challenge for people to say, oh, I just love kids. Oh, except that there's a lot of really not such nice things about, or can be, working with kids. It can be very sad. Children die. So that's the reality of it. So I guess you have to have a little bit of a shell for your heart, right? That because you see these families every 3 months. So you know them, right? You know them. You see them every 3 months. So, but love, attention to detail, and problem solving. Okay, here's a problem. How am I going to fix this with these limited factors that I have available to me? So I absolutely loved metabolic disease. A lot of people did not like it at all.
It's so nice of you to share this with us. And working with the family, detail-oriented, liking to problem solve, problem solving over time. That is such great advice for our students. Well, thank you so much, Peggy, for sharing all your time today. I think this has just been excellent. Thank you.
Oh, you're welcome. It's a pleasure, especially since I didn't get to know you all.